Hi, good afternoon, everyone. Thank you for joining us for Advanced Echo Teaching in the Critically Ill today. Great pleasure to introduce Behny Samadi again. Behny's an intensive care specialist here in Sydney, recently got her American Echo Board exams, and this is the sort of second, I guess, in her congenital heart disease lectures. She gave an amazing one a couple of weeks ago on ASDs that I love, particularly the drawings, Behny, and I'm looking forward to seeing these again. So Behny's going to be talking to us today about ventricular septal defects. I'm afraid to say I do apologise if I'm not here and I'll turn my camera off just for the first bit. I'm working clinically and just have to jump to the floor, but I will be back halfway through and I'll watch this again when it's being put up on our website. So thank you, Behny, and I'll see you shortly. Thanks for taking the class.
Thanks, Sam. Alrighty, so Tom, you're gonna have to be my sounding board and tell me if I'm going too fast or if I've made some glaring mistakes. So, so the bad news is my drawing skills have not improved since last time. So you're gonna have to put up with some pretty awful sketchpad drawings. Anyway, let's get started. So VSDs. So there's a couple of different types. The most frustrating thing when you're learning about VSDs is actually the terminology, because everybody calls things different things. But I'm going to try and make it as simple as possible and just break it down to the bare essentials of what you need to know. So when you're looking at a VSD, or you think someone might have a VSD and you're trying to evaluate them, there's two things you want to look at: the size and location. So really the type of VSD really describes the location, and I'll go more into that later. And the size is just small, restrictive, moderate, or large. Large is going to be glaringly obvious because it's going to be associated with like other complex congenital heart diseases. It's not going to be, you're probably not going to be an isolated large VSD. You're probably going to, it's going to be part of some like tetralogy or some other syndrome, some other constellation of congenital heart disease. What you will probably see in adults is these small restrictive VSDs, because they go basically unnoticed for a really long time and they don't cause a lot of hemodynamic effects. So people can go right into old age with VSDs. I've seen a small VSD found in like an 80-year-old for the first time. People are actually can be born with multiple VSDs. Apparently it's not that uncommon in newborns, but the vast majority spontaneously close. So the different types are, so you can go acquired and congenital if you want to break things down in exam format. So acquired, really, like what we're talking about is your post-MI, and I'm not going to talk about that really today. I'm going to talk about this congenital group, and you have membranous and muscular. And of the three, muscular, inlet, outlet, and trabecular. And that's all you really need to remember. And we'll go into where they are. So when you're looking at VSDs, other than size and location, what you want to look for is look at the adjacent structures. Partly because if you find one defect, then you want to make sure it's not part of a constellation of some sort of congenital disease. So you want to look at have a good look at other structures and make sure that everything else looks normal. And then the other thing is you want to make sure that there's no like complications from the VSD. So a VSD that's right under the aortic valve, for example, can actually trap the leaflet of the aortic valve and cause this Venturi effect and like suck it in. So then you get horrible aortic regurg as well. So that's something that you need to be aware of and identify on the echo as well. Unlike ASDs, VSDs cause left heart enlargement. So that's a really crucial point. So if you have unexplained left atrial and left ventricular dilation, the right side looks pretty normal, maybe the right ventricle is hypertrophied, that's the hemodynamics associated with a VSD, because you've got increased pulmonary flow. So you've got blood going from your left atrium to the left ventricle, back to the right ventricle and into the pulmonary circulation, then left atrium, left ventricle, right? So you're getting this recirculation of blood through the pulmonary circulation. And they say 1.5 times more then the systemic circulation means it's significant. You can work that out on echo. It's called QPQS, but it's fraught with difficulties. So generally it's recommended not to even bother. But you can tell about the hemodynamic effects because you'll have the left atrial enlargement, left ventricular enlargement, and the right ventricle will start to hypertrophy. And as that gets worse, then you start to get moving towards that spectrum toward the Eisenmenger's physiology, right? And so then you get an equalization of left ventricular and right ventricular pressures, bidirectional shunt, and then the right ventricle takes over, you get right to left shunt. That's really advanced, and you're really only likely to get that with the large VSDs. So again, probably not something that we're going to see as a primary undiagnosed thing. So that's the importance of looking at all the heart chambers, identifying left heart enlargement that doesn't have an obvious explanation because it could be a VSD that hasn't been identified, and look at the pressure overload on the RV and pulmonary hypertension as a secondary result of that. So with ASDs, you get right heart enlargement, you get a right atria because the blood's going to the right atrium first, then right ventricle, then through pulmonary circulation, then left atrium, right ventricle. But that doesn't generally tend to get bad enough to cause pulmonary hypertension. It's less common. But in VSDs, because we're talking about ventricles, higher pressures, they probably will result in some, it's more likely to give you pulmonary hypertension. And as I mentioned, it might be solitary or associated with a whole gamut of congenital diseases. This is just a few common ones: tetralogy of Fallot, truncus arteriosus, aortic coarctation, tricuspid atresia, double outlet RV, aortic regurg, which we mentioned, pulmonary stenosis, and then extracardiac stuff like trisomy of all the trisomies can have VSDs, and other syndromes can have VSDs as well. So this is what I was talking about when I said this horribly complicated terminology. These two are, this one is from a surgical textbook. So that's kind of, they have more descriptions of like anterior and posterior and things like that because I want to know, I guess, where it is rather than what it is. Is it a defect in what kind of septum of embryological origin? But I'll make it simpler. Okay, so I think the easiest picture to think about is this one. So you're looking at the right ventricle, like the right ventricle has been cut open. Your right atrium's here, your tricuspid valve sits about there. Your IVC's here, SVC's there, have your pulmonary artery here. And this is the outlet, the right ventricular outflow tract, just like there's left ventricular outflow tract. And that's this sort of, sometimes it's called cone, a conus, or an infundibulum, because it's got that like kind of almost a funnel shape. Same with the left ventricle, and that embryologically is the same origin that forms the pulmonary artery. So this is all from the same embryological origin. Then this part of the inlet septum, that embryologically forms from the valve, moves down from the valves. You have a membranous septum, which forms from the endocardial cushions, which form part of the valves as well, and the atrial septum, and that moves down. So that's the membranous part of the ventricular septum. And then all of this stuff here is muscle, and that has actually grown upwards from the floor of the ventricle in that direction. So that's important because that's how the VSDs are named. So we have perimembranous. It's also called membranous or infracrystal. Sorry, let me move that there. Or paramembranous. It's the most common, 80 to 90%. So if you're going to hedge your bets, pick this one. If you're not sure what it is, it's this one. And the Gabot defect, even though the Gabot defect is actually a communication between the right atrium and the left ventricle, it's not technically a ventricular interventricular septal defect. It's classified in this perimembranous group of VSDs, because you can have a VSD of just this membranous portion, but you're actually more likely to have the membranous plus something else. Membranous plus outlet, membranous plus trabecular, membranous plus inlet. That's why I chose, and I think the more common terminology is perimembranous, because it's not just membranous, it usually involves some other part. And that's because as they're growing, they grow together. And then if they don't quite join, then that's your VSD. So that's why you kind of have a defect in both, whatever's growing towards the other one. Then another part, this is part of the rest are all muscular. So they're all part of this is all muscle. So outlet is also called conus, because this is a cone, or subpulmonary because it's under the pulmonary valve, or infundibular because this is also called infundibulum. It's also called supracrystal because, sorry, I should have put that. The crista is this thing, is this band of muscle, starts from about there and moves, like if you're looking at this diagram, this comes out towards you. So it comes towards the this band of muscle that goes from there to the anterior right ventricular wall, or the free wall. It's a completely, I think it's a pointless piece of anatomy, but surgeons can identify it. So surgeons might call it supracrystal or infracrystal. So in this one, if there's a VSD, they might call it supracrystal, because they're referring to that particular bit of anatomy. Or it's also called subarterial, because it's again under the pulmonary artery or the aorta, which you might connect to, so under the arteries of the heart. And one of a special type is called doubly committed juxtaarterial VSD. It's a very long name for something that's actually very simple. It just means that you have a VSD in the outlet septum, just like all of these are all synonyms. But instead of going to it just goes directly across that partition to the left ventricular outflow tract. So it's like the corresponding part in the left ventricle. So, and if you remember from your embryology, you have a truncus arteriosus, and then that part that kind of divides in half in a spiral way to get your pulmonary artery and aorta. Yeah, it just means that there's a defect in that partition. The next type is inlet. So it can also be called inflow, and it sits around here. It's just under the atrioventricular valves, and it's actually usually part of a spectrum of congenital heart diseases called atrioventricular canal defects or atrioventricular septal defects. Again, naming the same thing, different terminology. And it's just a spectrum of congenital heart diseases that include ASD, the atrioventricular valves being fused, and a VSD. So that canal is defective. So the point there is that you probably won't see a VSD, an inlet VSD by itself. It'll be with an ASD and some sort of valvular abnormalities, tricuspidal mitral. And then the other one is muscular, also called trabecular, because it just sits in the very heavily trabeculated portion of the left ventricular muscle, the right ventricular muscle, when we're looking at it on this diagram. And then the surgeons you might hear them break it down into more specific, because it's a pretty big area. So they might say it's apical, they might say it's mid, so it'll be in the middle, and you might have lots of little ones, and they call that Swiss cheese. And what's interesting about that is you can actually have Swiss cheese on one side and they all coalesce to become one hole on the other side of the ventricle. So all kinds of permutations are possible. So this is just a clearer diagram that shows that this is the heavily trabeculated portion. So that's what we call trabecular or muscular. Technically, all these three are muscular. Outlet, it's at the outlet of the ventricle. Inlet, at the inlet of the ventricle. And membranous or perimembranous, because it involves the membranous septum. So that's the classification based on congenital heart disease segmental model of anatomy. Is this all making sense so far?
Yep.
Cool. So this is a little test. Do you want to have a go at naming?
Oh, have a go. That's first lecture. Don't promise anything good. So naming where each of these defects is that what you're asking for?
So how do we start with this one?
So that would be what are we? I'm just remembering the options. So we've got all the muscular. So this would be inlet.
Yeah, inlet. Yeah.
Yep. And then there's a bunch there that would be muscular.
Yep.
So, or trabecular, sorry. And
yep.
So then maybe this one would be on the right hand side would be the apical one.
Yep.
Is there maybe a Swiss cheese one above? Oh, sorry, above that.
Yep. Swiss cheese, yep.
There. So then what were we saying? That looks somewhere between muscular and so mid.
Mid, yes, mid.
Perhaps?
Exactly,
Yep.
Mid muscular, exactly.
Yep.
And how about this one right under the
outlet?
Yes.
And then would you call that periseptal, were you saying? Or
I'd call that
perimembranous, sorry.
Perimembranous, yeah.
Yeah.
This one probably, perimembranous. They probably both are.
Yeah.
But this one probably goes into the outlet more.
Yeah.
Or because I don't find this diagram super specific, like it's not super specific. This could be outlet. And then this one is actually the specific outlet one that's called doubly committed. So that one's the one that goes straight through to the other side.
Why is there a good reason for it to be called doubly committed, or is it really just a hole between the two outlets?
I think it's just a hole between the two outlets. I don't know.
Okay, cool.
Because they want to be difficult. So this one says, so this is sort of, I think this is outlet defect. And outlet defect. They just say outlet defect. And they, perimembranous. Yeah, they don't have an extra one here. That's probably, still perimembranous. Plus outlet, because you can have both. So when you're looking at this when you're looking at an echo, this is the picture that's commonly thrown up. I find it really hard to follow, to be honest. So I found a better one. I like this one. So again, it's got this super simple terminology: outlet, trabecular, inlet, membranous. None of this like infundibular, blah, blah, blah. It's just named according to like common sense. And then, and then here are the views. So the only thing I'll say for this particular diagram is, okay, so when you're looking at the short axis and you're looking at the level of the aortic valve, every diagram I've looked at actually has something slightly different. I think it's highly variable, and I'll show you what I mean in a second. So here's another one I think it's pretty nice to follow, but the problem is the terminology. So subpulmonary and subaortic are the same thing. Perimembranous is perimembranous. Inlet is inlet, but mid-muscular, marginal, and apical are all the same thing. They're all your trabecular muscular defects. So that's why I kind of put this one up in case that's helpful for anyone, but it annoys me that they didn't simplify it. And this is what I mean. So this one actually says something slightly different. And the difference is in the middle here. So when you're at the short axis at the level of the aortic valve and you see some color flow, On the right, just under the pulmonary artery, the pulmonary valve, that's always going to be your outlet. So that makes sense, right? You've got your aortic valve in view and the pulmonary valve, and it's pretty close to those two. So that's going to be an outlet VSD. On the other side, you have your tricuspid valve here. And next to that is going to be your perimembranous. But this is variable in every, this in the middle is quite variable. So I guess just don't take what you read as gospel. So in this one, they've got two greens. So they've got outlet and perimembranous. So that middle one is different to what we just saw. And on this one, so they said perimembranous, inlet, outlet, and then outlet. So like, yeah, I think it's a little bit variable what they're talking about. But I do find this picture helpful. And I've just put in where the intraventricular septum goes between the valves. So, sorry. So you can see you have, sorry, there's shortcuts built into my mouth, so I can't get rid of. So you have the mitral valve and the aortic valve on this side, tricuspid valve and pulmonary valve. And then in between them, so you have your outlet VSD in between the pulmonary valve and the aortic valve. You have your inlet VSD between the mitral and tricuspid valve. And then your paramembranous or perimembranous between the tricuspid and the aorta. That's also where you would get a Gabot defect if you're a little bit higher and looking into the atrium, in the right atrium. And infracrystal, that doesn't mean anything to me. Yeah, they all just have.
So is infracrystal trabecular or is it?
No, infracrystal is inlet, I think. No, it's perimembranous, sorry. Perimembranous.
Okay.
Let me see. Yeah, it's perimembranous. So this is the crista. So they call supracrystal outlet and then infracrystal are perimembranous.
Cheers.
So yeah, so infracrystal is perimembranous. And that's perimembranous as well. Like this is what I mean. This is the terminology hole that you can go down. But the perimembranous, outlet, inlet, and trabecular muscular, that's pretty common from what I've been taught and what I've seen researching for this talk. That's probably the most common when you're looking at echo and congenital heart disease and embryology anatomy. That's kind of how they refer to it. It gets a little bit more complicated if you're looking at surgical papers and things like that, because they're describing it with anatomical relations. And I think that gets very, in the adult, which gets very confusing. Personally, I describe it this way because I find it much easier to understand if I know the embryological origin, like how this happened, where it came from. And here's a slightly more detailed picture. Again, so mitral valve, tricuspid valve, your aortic valve here, and your pulmonary valve here. Your pulmonary valve is the most anterior. And a couple of interesting things to point out is this atrioventricular septum. So that's where your Gabot defect would be between, that's that part of the septum that goes between the atrium and the ventricle. And yeah, so you can kind of see the relations. The other interesting thing, just because we have the picture up, is the mitral valve and the aortic valve are close together. There's no wall in between them. It's just fibrous tissue. And it actually has a name. It's called the aortomitral curtain. But in the right ventricle, the tricuspid valve and the pulmonary valve are separated. So the pulmonary valve is all the way over here and the tricuspid valve is here. And there's a muscular separation between them. There's muscle in between them. So when I do a quick little diagram of the right heart, so I draw it kind of like a heart. No, that's terrible. Let me try again. I told you my drawing had not improved. So it kind of looks like that. It kind of looks like a heart in a heart. And then your pulmonary valve is up here and your tricuspid valve's there. And then here's the muscle that separates them, and like your aorta, aortic root passes through there. And then you're going to have, coming from here, the membranous part of the septum. This is all inlet. This is your little cone. So that's your outlet. And then all of this stuff is trabecular. Make sense?
Yeah.
Yeah, I think that's probably I should just stop there while I'm ahead. So
While you're winning on the drawing.
I wouldn't want to go and do any more drawing. So I've got a case, some cases, probably more in line with what we'll see. So I'll play it and you tell me if you can pick what's going on. So the first one's just let me do this. The first one's just a 2D echo, there's no color, just to orientate you. So what view do we have here?
April 4.
Yep, cool. Okay, now we got color. So we've put color on to look at tricuspid regurg, but can you see anything else going on there?
There's this small, might be imagining this tiny little flash of blue going from the LV into the RV. Just seeing when it's happening.
Yeah. It's
very, very subtle. Just
tiny little flash of like blue coming this way and then red going that way.
Yeah.
And this actually raises a good point in that VSDs can contaminate your TR jet, because if you put a Doppler through there, you're actually going to be getting a bit of your VSD jet, not just the pure tricuspid regurg.
Yeah.
Get your TR pressure. Okay. So I think, so maybe there's something there. I can't quite see a VSD on this though. So let's have a better look. So we've zoomed in a little bit more and we've got color more over the septum. So here's your left ventricle, your right ventricle. Can you see what's going on there?
Yeah, you can just see a little narrow jet of color just down near the valves. Yeah,
exactly. Yeah. So we're kind of almost in a 5-chamber. I know it's not that clear on this, but just believe me, it's
so you can just see the jet coming out the aorta there.
Yeah, exactly. So you got this turbulent flow, and then across this way, like horizontally, you've got this flash of green. So that's more turbulent flow. So that's going through the VSD. It actually doesn't project very well, so I apologize for that. And I've got a couple more views. So this is a zoomed in view of a short axis at the level of the aortic valve. So kind of just below that, it should be at that Mercedes-Benz sign level, but we're probably just a touch below it. And you can see this little jet coming on the left of the screen. And that's just it was right near the tricuspid valve, right? Your tricuspid valve would be over here. It's off the sector on this.
So it's an inlet.
Is it? Let's go back. Hang on.
Oh, is that membranous? Oh,
it's
no,
membranous. Hedge your bets, man. 80 to 90% of membranous. You got to just hedge your bets and say membranous.
What have I just walked back in on? Oh my goodness!
I just failed my test.
Sorry to be late. Hi.
So, Sam, you know how during my ASD talk, I always say, like, if you're not sure, or even if you are sure, just say it's a secundum ASD.
Yeah, absolutely. It's always
a secundum.
Yeah.
This is a similar sort of tale, really. It's always membranous /
excuse me a second.
And then I've got more images to show you. Okay, so this is again just the 2D to orientate you. This is your, what view is this?
So apical 3.
Yes, perfect. Yes, apical 3. This is the aorta coming here, and the atrium, left ventricle. And then go one with color, hopefully. Yes, so same view but with color. And we've actually got a little bit of the right ventricle coming in here. So can you see that there's this little flash of turbulent flow going left to right?
So it's coming from the aortic outlet, but because it's all named based on the RV.
So this is going from, so there's left atrium, left ventricle, right ventricle, and we're kind of in a something between a 3-chamber and a 5-chamber, and it's just below what should be the aortic valve, right? So I'm going to go back to the pictures because we've seen it kind of just below the mitral valve, we've seen it just below the tricuspid valve, we've seen it just below the aortic valve. So I'm going to go back to the diagram, this one. Okay, so we saw it come out just here on the short axis, and on the apical 3-chamber we saw it here.
That's a great diagram.
Yeah, it's a good one, yeah. From Thoracic Key, it's a good website. And then on the 5-chamber we saw it going across this way. Do you remember? There was one of the earlier images. So it's membranous.
They're always membranous, apparently.
Yes, exactly.
There'll be congenital heart people all over the world turning over. Yeah.
Yeah, I mean, 80 to 90% membranous or perimembranous. They're going to involve the membranous septum. So if you're not sure, and I think, you know, I would not even remember this. I would keep this somewhere in my pocket or online for me to access, because I would look back at this diagram and try and figure out what kind of VSD it is, because it's really complicated. And I think even if you understand the anatomy and the embryology of how they formed and where they are, once you convert that into echo views, it's still quite hard. It's like you're fanning through a 3-dimensional structure, and if you're going a few millimeters this way or that way, then you might not have it in that view. You might have a slightly different view, and then it becomes a different part of the septum altogether. I think that was my last. Yeah, that was the last one. So
we go back and screenshot your that picture as a cheat sheet.
Yes. Yeah. You can Google it.
You can Google it, can you? I was just going to send around to the group. I think it'd be fantastic.
Google Thoracic Key VSDs. It'll come up.
Right.
Or VSD image search on Google, and it comes up with that. I was looking for this picture, and Sam was saying earlier, I don't find this that helpful. I find this hard to remember. I think this one's a nicer one.
Yeah, absolutely.
And while I've got you, I'll just tell you about a couple of, like I did last time, a couple of free online learning resources that are really good. So one I mentioned last time, and I've looked at it for this VSD talk as well. It gives you a brief overview of the VSDs. Is the European Society of Cardiology. You just it's free to sign up. So you sign up, and then you sign up to acute cardiac care. Again, free to sign up to that. And then you have access to 2 free modules, one of which is adult congenital heart disease, or what they call grown-up congenital heart disease, GUCH. And they've got great little snippets on the congenital heart disease, explains it very simply. And they also have ECG, X-rays, cardiac MRI, and echo. So like for this one, you can see, so this is a much more
Larger hole.
Yeah, like a much more, can you see it? So it's quite,
Yeah, very nice.
yeah. So this is a muscular ventricular septal defect. Says a little bit more like apical than the membranous one that we were looking at. And this one is looking at a residual ventricular defect through here and that's on the toe, as opposed to transthoracic. So really great little resource there. And then the other one, which I didn't mention last time, which I had forgotten about, but I was introduced to this during my brief placement at BC Children's Hospital, which is a congenital cardiac center. And they got me onto this. So Open Pediatrics is by Boston Children's Hospital. And again, you sign up for free. And once you sign up and you say, this is, put your name in, and you say you're a physician, and you can access all this great content. And some of it is, there's a lot of congenital heart disease stuff on here. So if I like do a search for like tetralogy, for example, it has all these great videos on it. And yeah, and I quite like this because it's, I haven't looked at it for a few years, but when I looked at it a few years ago, they've updated it. It looks much fancier now. It was like super simple explanations of very complex things. And what I liked about it is they would tell you what happens when they repair it, which is what you need to know for the national board exams. So when you repair that congenital heart disease, you also need to know what that looks like and what the complications of that are. So you can look for those complications in your adult population. Yeah, so I think that's everything. Do you have any, I'm sure you have questions. Any questions before I leave you?
Stimulus to go back through embryology and
yeah, it's awful. Sorry. I was going to be like, don't worry, this is simpler than ASDs. And I'm like, that's a lie.
No, it's not.
That's a lie.
but it was a nice simplification of the classification and approach. So thank you very much, Behny.
Yeah.
Benny, thank you very much for doing that. Especially the free things at the end are fantastic. The educational resources are great. And I guess that's sort of what we're trying to do with our Echo website, isn't it? Trying to make them nice and easy, free, and good education online.
Yeah, definitely. Because I always like to talk about the real experts because I'm just really telling you what I learned from them. and
That's all right.
Go to the source.
Benny, thanks very, very much indeed. It's absolutely a pleasure to have you talking to us again. Thanks a lot.
No worries. Thanks for having me.
Thanks, Behny. Cheers.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.